Good morning. This clock is fast. I'm going to say it's 7:31. Welcome to Grand Rounds. Happy Leap Day, leap year. We are really excited to hear from Dan Matlock. Before I introduce him, I'll remind you that next week is also a Grand Rounds, first Thursday. We have a visiting professor, Ann Basting. She will talk about beautiful questions, infusing meaning and purpose into elder care systems. I highly recommend you coming. I first learned of her from Milwaukee. You'll hear more about her. Perhaps some of you have started reading her book, Creative Care, and that's our book club. So more to come on that. So please join us next Thursday as well. Journal Club is the following week, March 14th. Presenters are Sarah Tietz and Elizabeth, I believe. Please complete evaluations either online or on paper, and we'll take Q&A. Dan will finish with 5 to 8 minutes left so that we have some time for Q&A. He will. I forgot to email about that. Dan is the director of the Colorado program for patient-centered decisions at Accords. He was interim director of Accords and now is just back to his normal guy space, which we love. He has been funded by a lot of different entities, was a Beeson Scholar. He has participated in the American College of Cardiology's Shared Decision-Making Task Force and is also an active participant in the International Patient Decision Aid Standards Writing Committee. So he's also most recently appointed as our Associate Director of Clinical for the GRAC. So thanks so much, Dan, for presenting.
Thanks, Hillary. It's fun it's always nice to present to friendly crowds. You don't feel like you have to put on a tie and things like that. So I think the title in the email is slightly different than this. I got asked to fill in for this talk a couple weeks ago. And this is the slide deck I gave up in Portland to a private group of cardiologists and a bunch of patients. I tweaked it a little bit and added a little bit of stuff at the very end on the Anschutz Acceleration Initiative if we have time to talk about it. It's a same title, can go on a lot of talks. I give a lot of talks. I think the title in the email was Update on Shared Decision Making, and this is how do we implement policy mandates for shared decision making. But the theme is I do a lot of work on shared decision making. So some conflicts of interest. We talked about the funding, and I always like to tell people I am also a member of the American College of Cardiology, and they let you join as a geriatrician for $100 a year, but you have to apply. And you have to fill out this application. And on this application, you have to check a box that you're either a cardiovascular veterinarian or a geriatrician. I'm not sure what that says about cardiologists or the American College of Cardiology, but it's funny to me. And maybe a little bit ageist at the same time. All right, so if you've seen me talk, I was telling Hillary I had some anxiety because I think I gave Grand Rounds for geriatrics maybe 6 or 7 years ago. And there's a few of these canned slides that I think are fun that some of you may recognize if you saw me speak. But then I was thinking, we got a lot of new people, but I bet you a lot of people haven't seen a lot of these things. So I was like, okay, I'll just present some of these things. But think of this statement. There's a 30% chance of rain tomorrow. Now think about how you would explain this to like a 10-year-old. And I used to give a talk to the med students on risk communication and patient-centered care, and I'd present these slides. And I used to have them raise their hand and explain it, and I stopped that after the first time because it was pretty embarrassing hearing people try to explain future probability. It was really complicated. So there's this psychologist, Gerd Gigerenzer at the Max Planck Institute in Germany, and he does a lot of research on the psychology of decision-making, and he does all these little fun psychology studies. This was a people on the street study. And he asked 750 people, what does this mean? He gave them that statement. And he gave them 3 options. It'll rain tomorrow 30% of the region, 30% of the time, or on 30% of the days like tomorrow. The right answer is the last one, I'll just tell you. The most common answer for people on the street was it will rain tomorrow for 30% of the time. And one of the little sub-findings in this, there were 4 European cities, 1 American city, and the Americans actually did better, which was a surprise, and they hypothesized Americans have been getting percentages in their weather reports since the 70s, and apparently that was something that didn't latch on in Europe until the 2000s. So just kind of interesting. But some of the comments in the paper were also interesting that people said. 3 out of 10 meteorologists believe it will rain. 30% means if you look up at the sky and see 100 clouds, then 30 of them are black. It's not about time, and it indicates the amount of rain that will fall. Or if we had 100 lives, it would rain in 30 of these tomorrow. And I like that last one because I think it's correct. That is kind of what future probability is. It's a really hard concept. I talk about shared decision making, and a lot of shared decision making research has been around quantitative information, and we'll get past that because I think there's a lot more to sharing decisions than just the statistics. But I also think how we present statistics to people is an interesting thing to think about, and hopefully a couple tips you could take to practice today and do things differently in how you communicate that we'll get to. But this is a challenge, is poor numerical understanding. So here's a much more sobering example. In 1995, the United Kingdom Committee on Safeties issued this warning: oral contraception pills increase the risk of potentially life-threatening blood clots by 100%. And then this is a graph from a paper in the New England Journal about this. And you look at the rate of abortions, and I'm not making any social comment on abortions, but I think we can all agree it's a proxy for unintended pregnancies. And you look after that warning in 1995 in the UK, the large increase in the number of abortions, and the graph on births looked exactly the same. Whoops. And so this was the pill scare. This was the data. The actual increase is about 1 in 7,000 to 2 in 7,000, which is indeed 100% increased risk. But this gets into this relative risk versus absolute risk. And it's a relative risk of 100%, but it's an absolute risk of 0.014%. And this is the challenge. And then the irony is this last comment on the slide, that the risk of blood clots is about 10 times greater with pregnancy than it is with oral contraceptive pills. So they didn't actually prevent any blood clots with this horrible messaging. And this is the problem. This is this relative versus absolute risk. And that same psychologist I presented, Geriatric, has done a lot of work on this concept. And he may be the guy who coined the term denominator neglect. But the problem is when we hear relative risk, we don't think about the denominator of 1 in 7,000 to 2 in 7,000. We think about a denominator of 100. And even when I listen to NPR present a statistic and they say, oh, 20%, I'm like, are they talking about a relative or an absolute? Did they use the right words? And I understand the concept, but the words translating to the concept is really, really complicated. And one of those other papers that German group did, they looked at a lot of abstracts from journals like the New England Journal and JAMA in the 90s, and looked at how they framed risks, and the benefits were almost always relative risks. Aspirin causes a 20% reduction in stroke, but then the harms were almost always absolute risk. But there was a 1% increase in the rate of bleeding. And you're basically showing an apple and the orange. And now we know with aspirin, it's for most people kind of a wash. And I wonder if we adopted aspirin simply because of the way it was communicated to us for 20 years in the journals. So this is the kind of thing that matters. So I like to start with some of those fun slides about risk communication. We'll get into that a little bit and how we do that in the tools. But the shop I run is the Colorado Program in Patient-Centered Decisions. And we've done a lot of work on these decision aids. And I really like decision aids, especially for high-risk, discrete decisions. I'm not sure, and some complicated decisions. I'm not sure how well decision aids work for us in primary care doing screening, and that's where a lot of the research has been done. And I find that a little bit frustrating sometimes, that it's just kind of hard. But I think when we do things like, do you want a defibrillator? Do you want an LVAD? These big things that we do to people, I think they fit well. I'm working with Michelle Fuller in neurology right now. She just submitted a BSIN about deep brain stimulation for Parkinson's. I think these kinds of examples are great places where some standardized information could be really helpful. So that's what I do. And I'm going to talk about these two examples throughout the talk, our LVAD example and our ICD example, and just go through a lot of the work we do, some of the research we've done, and get into some of the implementation science questions that I spend most of my time thinking about. So let's talk about the defibrillators for a little bit. This is the New England Journal figure from the SCUD-HEF trial. This is now 20 years old, which is kind of crazy. But this was the figure that this was the study that convinced Medicare that they should pay for defibrillators for patients with heart failure who've never had a previous cardiac arrest. Previously, defibrillators were for people who were found down at the airport. Oh, you're at high risk of having this again. Let's put a box in you. And they're amazing. The engineer in me loves these things. They're amazing engineering feats. And if you look at this is a big, for preventive medicine in people who have never had an event. This is primary prevention. This is a big absolute risk reduction. If you look over 5 years, the rate in the placebo group, 36% died. versus 29% in the ICD group. That's a 7% absolute risk reduction over 5 years. That beats most of what we do with cholesterol and hypertension, unless they're diastolics like 120, then we get pretty big absolute risk reductions from those 1950s papers. But short of that, we're looking at small little numbers in a lot of the things we do in primary care. So this is a big benefit. And it's important for me to say that because I worry when I talk to cardiologists, I'll come across as like this nihilistic geriatrician who just wants you to stop doing things. And it's not that. You know, I have 3 kids, and if you told me I had heart failure and this could help me live longer, I'd probably get one. And then I listen to our patients in clinic say, I don't want a lot of things done to me. And I think, you know, there's a point in my life where sudden death is much better than a lot of the other ways you could possibly go. And I think that's the discussion I like to push. So we surveyed people at Kaiser, this is now about 10 years ago, everybody with an ICD, and we asked them, if 100 people like you had an ICD, how many lives would be saved by the ICD? And we gave them 5 options. This was a question that had been used in a previous study, so we just mimicked it. And you see the answers. 40% said 53 out of 100, 28 said 28%, or 20% said 28 out of 100, and only about 15% got it right. I just showed you it's 7 out of 100. Well, I'm just gonna grab my. Sorry, just a little dry this morning. So that is, I mean, that's the problem. When we communicate these numbers as relative risks, we create confusion. So let me sprinkle throughout this first part of the talk, I have these fun little psychology studies. This is Sharon Iyengar, Susan Iyengar. I think she was a postdoc at Columbia, did this study where she took a bunch of jams, colored jams, and she went to a grocery store, and on some days she had 24 different flavors, and on other days she had 6 different flavors. And when there were 24 flavors, 60% of people walking by stopped to look because it's a rainbow of jam. I mean, that's awesome. But only 3% of people actually bought one. Now, when there were a lot less, when the number of choices was reduced, 40% of people stopped to look, but then a lot more of them bought jam because they didn't have this decision complexity. This is a theme of a lot of the psychology of decision making, is we like to avoid complexity. We like to do easy things. We don't like to think hard. We don't like to make hard decisions. We like to work on an implicit bias or a heuristic because it's so much easier than thinking through cognitively the attributes of a decision. So a lot of the work in a decision aid is trying to get people to slow down and say, okay, yeah, it's scary. You're dying of heart failure. You got offered an LVAD. Let's slow down. Let's think through, is this right for you? So a lot of what we do is just trying to get people to think through these things. This is a fun study. But this is David Rettelmeyer actually published this with Dan Kahneman, a Nobel laureate, in JAMA. He did this study. This is now 30 years ago, but it's still a really cool study. And he just did a survey, and he asked docs like us, he gave him this scenario. You've got a 67-year-old farmer with arthritis. You've tried some NSAIDs, and you stopped them because they didn't work. So you're going to refer him to ortho and give him a hip replacement. Then half the people got the options on the left. Before you refer him, you check the drug formulary, and you find that there's one NSAID that he hasn't tried. What do? Refer and start the NSAID, or do you just refer? And then in the other group, the other half there's 2 NSAIDs you haven't tried. Do you refer and start ibuprofen? Do you refer and start piroxicam? Or do you just refer? And when they had a choice, when you gave the docs a choice to pick one of the NSAIDs they hadn't tried, they just said, forget it. I don't want to choose. Let's just refer them. Whereas you saw fewer didn't just refer, they decided to try the ibuprofen. It's exactly the opposite of what you'd think. And this is us. You know, doctors, and I'll show you another study coming up, we don't like to think we're subject to these psychological biases, but we are. It turns out we are all human. This is a fun study that was actually published in JAMA. So this is this behavioral economics stuff. These are the kinds of studies that psychologists do. And if you're interested in this topic, these are 2 great books. Thinking Fast and Slow by Dan Kahneman. He won the Nobel Prize, I think, around 2002 or 2003. Amos Tversky was dead, but he basically said this is our Nobel Prize because they did a ton of work together. And then more recently, Richard Thaler won the Nobel Prize just a few years ago for his work with this kind of thinking and nudge. And a lot of people have heard of nudge because it got used it a lot in the elections, and we get nudged based on the advertisements we get. It comes from this psychological theory. So this is probably one of their most famous experiments that I want to present. And I think other people may have presented this one before. It's a little outdated. They called it the Asian flu crisis, or but I'll just present it as what they did. So imagine the US is preparing for the outbreak of an unusual Asian disease, which is expected to kill 600 people. And then they had a group of med students, a couple groups of med students from different institutions. And half of them got the top choice and half got the bottom. So you're the public health officer and you got to choose a program. You could choose program A or B. In A, you'll save 200 lives. In B, which is the throw the dice one, the risky one, there's a 1/3 probability that 600 people will be saved and a 2/3 probability that no people will be saved. So the only difference between A and B is A, you save 200, and B, you have a 1/3 probability of 600. From expected utility theory, the old theory, these are identical. One's a risky option, one's a conservative option. And then the other half of the people got the same options, except instead of framed as saving people, they're framed as dying. People are dying instead of saving people. And then you had to choose. And when it was framed as saving, 3/4 of people chose the conservative option. When it was framed as a loss, 3/4 of people chose the risky option. And these are doctors. And these are huge differences just based on a framing of a word, saving versus dying. And this is what Dan Kahneman really won the Nobel Prize on, is this kind of stuff. This comes from prospect theory. And this shows that we're risk averse when faced with gains. We're risk seeking when faced with losses. So this is the gambling problem. Oh, double or nothing. I just lost money, so let's double it and see if I can get it back. You take more risk because you just lost something. Whereas when you just gain something, you're risk averse, so you buy insurance. So you buy $100 DVR player from Best Buy, and they offer you a $15 insurance. So they're basically saying, do you think there's a 15% chance your thing's going to break over the next year? If so, buy our insurance. And so people do. It's the highest profit margin thing that Best Buy has, is those little insurances they sell on these low cost items. Don't buy those things. Just insure it yourself with your bank account. You're going to save more money in the long run of your life. But they're playing with your psychology. They're playing with your risk aversion when faced with gains. You just gained your new toy. So just insure really high cost things that you can't insure yourself. That's, learning this study, I went back and I raised all my deductibles because it saves me money. So back to the examples with the LVAD and the ICD. Back to the ICD, here's that figure again. Now transitioning into some of the things we do, here's an advertisement that showed up in my box here when I was pretty early in my career, right after this study came out. This was from the electrophysiology group at the time here, which is a completely different group of people than it is now. So I'm not casting any disparaging remarks on them, but this is the advertisement summarizing the SCUD-HEF trial. There's a 23% reduction in the risk of all-cause mortality. This again showing the relative risks. But again, I want to say the ICDs are highly beneficial, but they come with a host of harms. And I won't spend a lot of time on this, but I'll highlight a couple studies. There's obviously procedural risks. There's one study that shows that people who get ICDs have more heart failure admissions. The reason being is you took this population of people who were going to die of sudden death and you kept them alive. Well, now they're going to the hospital more. This is that trade-off of modes of decline that we'll talk about a little bit more. Some studies around anxiety and depression and PTSD. These are a little bit frustrating because the randomized trials that could have really reported what is the attributable rate of a defibrillator to anxiety didn't really report it. About 30% of people with anxieties have anxiety, or with ICDs have anxiety. About 30% of people with heart failure have anxiety, so it's hard to know. But there's certainly case reports of people who get shocked and then have post-traumatic stress disorder from a defibrillator. I had a patient when I used to have a clinic in the heart failure clinic. I had a half day a week of primary care in the heart failure clinic when I was building relationships there. And I had a patient referred to me who had a nightmare every night that he was getting shocked by his defibrillator. And he would call and they would do the interrogation and nothing had happened. It's just a nightmare. He was believing he was getting shocked again because he'd had one shock and it was pretty traumatic. And it was a life-saving shock, and he was very thankful. And over time, his PTSD kind of waned after about 6 or 8 months. He stopped having the nightmares and did a little better. So, but there's a lot of those reports from things with defibrillators. A couple other interesting studies. This one, potential suffering at the end of life. That Nate Goldstein did a survey, and I actually have some more recent reference for these, but I forgot to bring that slide over. But he did a survey of hospices, and this was an older survey, but half the hospices in the country in the year prior to that survey had a patient who was in the hospice dying of some other cause that started getting shocked at the time of their death. So, these life-saving devices that are great, medicine doesn't get much worse than dying peacefully in hospice, and then all of a sudden your family's standing vigil around you, and then all of a sudden you start getting shocked. And at the time, half the hospices had that experience in the year prior. I think that's better now. I think hospices are a lot more tuned into these. They're a lot more common. The nurses know to check and then think about, oh, we don't want that to happen. But back then, when most of it was cancer, and this little box was a new thing, people thought it looked like a little pacemaker. People didn't think about it. It's just important to think about. But so there's a bunch of trade-offs. There's benefits and risks, but I actually think it's not about the numbers nearly as much as it is about sort of your values. And this gets into this mode of death. This comes from a conceptual model of patterns of functional decline that was published in JAMA by Joan Linney and Joanne Lynn and a few other people you may know. It's these patterns of decline. They had 4 patterns. I just have 2 of them here because these are the 2 that we put into our decision tool. But you might have heart failure going along, and you have these functional declines, and you never quite.
Is there a redeeming the dollar?
Oh, sure, why not?
I think somebody might have their mic on. And then these patterns of decline, and then you get to, and then you eventually die.
Thanks so much.
You.
You too.
And then you're going along, and then you can have just sudden cardiac arrest. And defibrillators only treat one of them. And again, I like to show these slides to the cardiologist because in the literature, especially cardiology, it's mortality is one endpoint. And I think something we know is mortality looks really different. And I think that's where some of the discussions around defibrillators really need to get to. It's not so much the risks and benefits and the trade-offs. I don't think patients care whether it's 7 out of 100 over 5 years or 9. It's, do I want to get this procedure that might shock me? And maybe I'll live a little longer, but then I'll have to deal with whatever progressive things I've got going on. I think that's the discussion that a lot of people are not having, that I would love to kind of convince people to have more when you talk about a defibrillator. So one of my survey studies, or one of my interview studies, we tried to interview people who'd accepted and declined, interviewed docs, and this was a quote from one decliner we found. And he said, going into my decision is also the fact that I can't work because of my medical condition. I can't work at the hospital. I can't work at the church. My life is sitting here watching TV. To take a defibrillator would just lengthen the process that I don't really want lengthened. And this was a former hospital chaplain. And of the 6 decliners we interviewed in this study, he was the only one who really got it. The other decliners had all other kinds of other reasons why they didn't get a defibrillator. Like I'm Black, and I looked at the studies, and there are no Black people in those studies, so this doesn't represent me. The trust issues. There were other reasons that didn't feel like a very informed reason to decline an ICD, that these other people were declining ICDs. This is the only guy who really understood this trade-off, but he's a former hospital chaplain who kind of saw it all happen. So we also did a national survey of cardiologists, and I wanted to find out how important do they think the patient's preferences are to this. So we teamed up with Duke, and the ACC let us send this out. We got 1,200 responses from cardiologists. And we asked them, to what extent do the following factors affect your recommendation for ICDs? And I was interested in patient preferences. And if you ask people, are patient preferences important? They say yes. It's a social acceptability bias. So in survey research, if you have something like that, where there's a social acceptability bias, you kind of hide it in a list, and you're more likely to get an honest answer. That sort of survey technique comes from people asking about things like drug use or abortions or things that people don't want to disclose. You put it in a list, you get more honest answers. So we asked people, and we gave them a long list of things, and mortality data and guidelines were scored 3.8 out of 4 and 3.6 out of 4. And then, but you looked at patients' preferences were 2.9 out of 4, Patients' knowledge about the ICD was 2.2 out of 4. And I'd argue there is a right answer here if you're really doing shared decision-making. Guidelines and mortality data should be 4 out of 4. We should recommend things that have really good data. But those recommendations should also be based on preferences and understanding. Then I think both of those should be 4 out of 4. So I think, but this kind of shows that that's not necessarily the way docs think. And there was a bimodal distribution too, especially around the preferences, where some of the younger docs thought were 4 out of 4 for the preferences, and some of the older cardiologists were 2 and 1 out of 4. Oh, those preferences don't matter. Those kinds of things. And so in our interview study of docs, this is a quote that captured, I think, some of it. I think my biggest concern is if I convey the risks to them too strongly, that they will choose or make an unwise decision and not proceed with therapy. And I called this a theme because it came up in 4 out of the 11 interviews. And I look at this, and this is something I've felt with some patients in clinic. I had a guy who had a pancreatic cancer and just he had a friend who got chemo, it didn't go well, and he refused chemo. Then he ended up getting pancreatitis, and lo and behold, he wanted chemo. And the oncologist said, no, now you're too sick, and he died. And I always felt concerned for that guy. Like, did talking about the risks and letting him make that decision, should I have pushed him harder to at least go talk to the oncologist? You know, those are the kinds of things. But I did talk about the risks and let him talk about these risks, and I think it kind of scared him. And I think that's the fear. And I called this paternalism, beneficence, which is what paternalism is based on. This is kind of how I feel when my kids are watching the news and there's a bad story. I may want to turn it off to protect them from it, but this isn't how I want you talking to my dad about his defibrillator decision. I want you just to be honest with him. You're an adult, he's an adult. Let's treat each other that way. So this is sort of a transition part of the talk here, but this gets into why I like shared decision making. Patients are sort of scared of being labeled a difficult patient. And this is obviously a Seinfeld episode where Elaine, the doc, walks out of the room, leaves her chart there. She picks up her chart, looks at it, and it says difficult patient along the top. And I'm sure she was a very difficult patient. And and the doc comes back in and she confronts him and said, why does my chart say difficult patient? He says, oh, that's a mistake. And he erases it. And she's like, you can't erase it. It was in pen. So, but this is a fear. There's a great study in Health Affairs that Dominic Frost did focus groups and asked people, why don't you question your doctors? Why don't you challenge your doctor? And they said, this was a quote that represented a lot of what they saw. He's like, well, is the guy going to be pissed at me for not doing what he wanted? Will he do what I want, resent it, and therefore not be quite as good, or in some way detrimental to my quality of care? I mean, this is the fear that people have. So this is kind of that to the extreme. This is a cover of BMJ from a few years ago. It was a special issue about patient-centered care. And I was like, oh, cool, what a great issue. There's a lot of great papers in this issue. And I was down at the International Shared Decision-Making meeting, which was actually being hosted in Lima, Peru by some folks at Mayo who were from Peru. And he had a speaker there who is a doc, an ICU doc who does human rights work. And he put this slide up. And the guy hosting the conference was actually the guest editor of this issue. He puts this slide up and just starts criticizing the whole issue and said, look at this iconography. Think of the suffering associated with this iconography in the last century. This isn't what doctors want. This isn't what patients want. Why do we want to talk about this using the language of revolution? Why don't we just be better and have better relationships with our patients and better communication? And it was a really cool kind of moment in the conference that he just kind of came out and challenged like that. But he made a spot on point, in my opinion. So that gets into shared decision making. In terms of care quality, this whole concept of shared decision making is based in this quality domain of patient-centered. You guys have probably seen these where the 6 domains of quality, good quality care is safe, effective, equitable, efficient, timely, and patient-centered. And people use the term patient-centered in all kinds of ways, I've found. But the way they define it is patient-centered is providing care that is respectful of and responsive to individual preferences, needs, and values, and ensuring that values guide all medical decisions or all clinical decisions. So it's all about those values, and are the values guiding the decisions? That's what good patient-centered care is, at least as people define it here, and I adopt these kinds of definitions too. This is not shared decision-making, but this is the way, I think, when we were residents and you're talking about code status, this is the way a lot of us sort of sort of lumber through our first attempts at being patient-centered is throwing options and say, well, it's not really my decision, it's your decision. But this is not sharing anything with a patient. This is just kind of skirting your responsibility as a doctor to help somebody make a decision. A really common question I get when I present to cardiologists is like, great, Dan, but patients come to me and they want a recommendation. Can I give a recommendation and still be doing patient-centered care? And I say, of course you can. And I'll try and talk about an example of that here in a bit. But that's a common concern. So the way more recent definitions, and I won't get into this too much, but the National Equality Forum has a nice definition of shared decision making. If you just look at the 3 bullets, it says you need clear, accurate, unbiased evidence. Second bullet, you need clinician expertise in communication and tailoring of the evidence. And then the third bullet is the patient's values and goals and informed preferences. So basically, if you bring these things together, you're sharing a decision. My favorite definition of shared decision making, actually, I don't even think they meant to define it, but they called it a meeting between experts in this book in 1985. And I like that because it's not wonky, but it just acknowledges the shared expertise. You as a clinician are the expert in your clinical area, but they are an expert in themselves. And if you see them as an expert in themselves, then all of a sudden you've just equalized the footing and you put yourself on level ground and you can share expertise. And then so you can make a recommendation. You can say, of course, I recommend a defibrillator. Your ejection fraction is less than 35%, and you have class 2 heart failure. Or you could say, well, based on your ejection fraction of 35% in class 2 heart failure, and the fact that you just told me you want to live as long as possible and you don't mind getting shocked, I might recommend a defibrillator. What do you think? Both of those are recommendations. One of them, I would say, is from a shared decision and is very patient-centered. One of them was a well-intentioned paternalistic medicine. And so I think that's some of the behavior that I think you can kind of move towards, is just seeing your patient as an expert. So getting into a little bit of decision aids, if somebody's interested in making a decision aid, I'm happy to sit and give you a 60-minute talk on methods to do that, but I'm not doing that here because I thought I'd bore people. But there are some standards. These are national patient decision aid standards. I was on some of the update committees for some of the chapters that supported, and they actually just got an email yesterday that they're updating the standards again, and they're doing a Delphi panel, and they're having people vote. If you are interested and know something about decision aids, you are eligible to vote for the new updated standards as part of this early round Delphi panel. Let me know. But a decision aid really has 4 big areas: provide some information about the option, provide some information on the probabilities of the pros and cons, provide some method for clarifying values. And that's really what makes a decision aid a little different from an education document. It's not just about presenting information. It's like, okay, now you've seen the information. What about you? What's right for you? Are you this kind of person or are you this kind of person? And there's lots, I think the science of decision making needs a lot of work on how we clarify values. There's explicit methods where people rate and rank, and discrete choice experiments and conjoint analysis. And then there's more implicit methods where you use like imagine futures. We tend to use more of these implicit ones because I think these are really hard to implement. But there's a lot of ways people try to help people clarify their values. And that's what makes a decision aid a little different from an education document. And then finally, some structured guidance for deliberation, preparing people for preparing people for those next steps. Well, what questions do you have for your doc? Are you ready for a decision? Those kinds of things. So do these things help? There's a Cochrane review of decision aids, 205 trials, and they almost always help in these decision outcomes: improving knowledge, improving communication, improving involvement, improving satisfaction, lowering decision conflict, lowering regret, lowering the proportion undecided. I mean, I actually asked the person who led this trial at a recent conference, I'm like, do you think we can start saying there's a class effect? Do we need to do a randomized trial for every new decision aid, for every new decision? She had a pretty good answer. She's like, well, we probably need to keep asking for that so we keep getting funding, because if we call it a class effect, they're going to stop funding us. I'm like, oh, that's smart. But then she also said, and it probably depends. Like, so if you're going into a really new context with a new complicated decision, like say the new dementia drugs, we just wrote a grant and we haven't heard yet on these new dementia drugs, probably need to do some deeper study to see if shared decision making helps in that space. But in general, we know a lot that a certain design can really help and work. So I wonder if we need to do an RCT for every decision aid, or if we can build on prior work and use those methods. A good rigorous development process, is that all you need at this point? I think that's a debate that the decision science community needs to keep having internally. So back to this figure again, I've shown this a couple times. Here's that same figure presented in one of our decision aids, that same data. This is called an icon array or a pictograph. University of Michigan did a lot of work showing if you present data this way, people are much more likely to understand your statistics in the months afterwards, or the weeks and months afterwards. And you see that 7 out of 100, those are the little green faces. And this is something you can do in your clinic now. I try to never use a percentage when I talk in clinic. I try to convert everything to a base 100 frequency. Oh yeah, it's about the risk of statins is not 5% for muscle problems. They say, oh, about 5 out of 100 people might have some muscle pain from statins. And there's a lot of research that people tend to understand those natural frequencies better. And then it forces me or you to not use a relative risk accidentally, because you have to use an absolute risk if you do a base 100 when you present statistics. You just are kind of forced to. So I try never to use a percentage in clinic if I can avoid it. So with defibrillators, they've had a lot of adoption. There's class 1 guidelines for defibrillators now. There's a Medicare mandate that people getting a defibrillator need to have a shared discussion. This mandate came out right when I was starting an R01 that I'm not even going to present because it's so frustrating. And this mandate kind of ruined the R01 because it said everybody needs a decision aid. So my entire control group now had to have the intervention we were going to study. It's very frustrating. But one fun thing in this, they referenced our decision aid when they made this mandate. So we get 400 or 500 hits a week at our website of people, these electrophysiologists around the country, trying to meet this mandate using our decision aid. But that's kind of a unique thing. The challenge, I think, that Cochrane review of 205 trials, most of them are the research assistant sits with or near the patient, make sure they go through the decision tool, and it improves patient understanding and patient empowerment. But nobody uses these things in the real world. So we have this big evidence base for these things that are just really hard to implement. So I'm going to go through a couple implementation examples with the ICD and the LVAD. I'm going to compare and contrast them a little bit, because most of the grants I write are implementation science grants. And our AAI grant that we got is all around implementation. And how do you develop things at the time you develop? How do you develop something that's ready to be implemented? But there's tons of questions you have to answer for implementation. You can make a tool that helps people, but who's going to give it to them? How will it be delivered, electronically or in person? When's it going to be given? Is it going to be given before the visit, after the visit? Is it designed to be used during the visit, in which case it needs to be really short? And medical decisions require different depths of deliberation. Some of these little daily reversible decisions probably need a very different design than you're dying of heart failure and you're going to get maybe one of the most major surgeries we do, an LVAD. I think those are very different decision contexts and very different decision needs. So I think they need a different design of a tool. And these are some of the examples we've done. So I'll get into our LVAD a little bit here. So with our LVAD, we have an 8-page decision aid and a 28-minute video, I believe. These are two guys who've signed video releases. They're both people who are video, Cliff and Don. Some of you may recognize Cliff because he was on a commercial with Jake Plummer advertising UC Health a few years ago. His biggest comment is he's happy that he got the Bronco symbol in our video when he saw the video, because he was wearing this Bronco hat. I mean, he's a great guy, but he got an LVAD, did extremely well. Don Brees lived up in Buena Vista and said, I don't want that. Please stop offering me that. I get that you care for me, but I used to work for insurance and I know what this is going to do for everybody who's in my insurance plan. And I don't want this. And I'm very comfortable with my life. I'm a very spiritual person. If I die, it's okay. And he didn't get an LVAD. And so it's a cool part of the video. And you just compare and contrast. This is our value clarification we put in here is, here's one person, here's one person. The narrator comes back and say, all right, you've heard a couple perspectives. Now what's right for you? And so I think most people here probably know what an LVAD is, but just in case you don't, it's a pump and you open the chest, you plug it into the ventricle, you suck blood out of the ventricle and you pump it down the aorta. That's it. Huh? Yeah, that's how I present it to people. And no, I'm kidding. But, and then it's a pump, so it has to be attached to a battery. And then you have to wear this 7-pound vest of batteries. There's some really interesting stories in some of our qualitative studies of like the guy in the fishing boat where his batteries were running out and they were 45 minutes out. And his wife met him on the dock with replacement batteries as they're speeding into the dock. Like, so these are burdens. But these were, for a few years ago, these were becoming more common. There's Vice President Cheney showing his LVAD. He had one for a couple of years before he got his transplant. The rates of LVADs have slowed a little bit through the pandemic, and the fentanyl epidemic there's some sobering things that I just was talking with Larry Allen. They did 69 transplants last year, and he thinks about 40% of them were fentanyl. So the number of transplants has almost doubled because there's a lot more young hearts available. So there's fewer people getting LVADs. So that's a horrible thing to think about, but that's a phenomenon that's going on. But LVADs they were surpassing transplants because they don't have the scarcity problem. Heart transplants are limited by, we only had about 2,000 available hearts a year. LVADs, they're $300,000 each, so there's a economic scarcity, but we don't talk about that in American medicine. So essentially, there's as many as we want to put in. So we did a big trial of the LVAD. We did a 6-site study. Larry led this, and Larry Allen, our head of the division head of cardiology now, former head of heart failure. I work with him a lot on this stuff. But he led this trial at 6 sites, and we implemented using a step wedge design. And we measured this outcome of decision quality. This is one of the outcomes you measure in these decision aid trials. Decision quality has 2 domains. Are they more informed? And was the decision concordant with their value? So we measured knowledge, and we got about a 5% increase in knowledge. So people who saw the decision aid in the intervention arms were more knowledgeable, but a pretty small benefit. The average in the Cochrane review is 13%. So I don't know if these patients were coming in a little more informed or what was going on, but it was a small benefit of knowledge. But then we saw a big benefit in values concordance. And it was a cool area because a lot of the value concordance work is hard because there's multiple values. With an LVAD, we could almost distill it down to one value. There's a lot of other things, but this one rises above all the others, this trade-off of living longer versus invasivity. So let's just measure that. Have people put a line, an X on a line, would you rather do everything you can to live longer, even if it means having major surgery and being dependent on a machine? Or do you want to live with whatever time you have left without going through major surgery or being dependent on a machine? And had them put an X on a line. And if they put an X down here and didn't get an LVAD, we called these concordant. If they put an X on the far left and then didn't get an LVAD, that was a discordant decision. And our intervention had a huge increase in values choice concordance. We actually used this Kendall's tau, which I'm not going to be able to explain to you. It's a correlation coefficient, essentially. And we saw a pretty large increase in Kendall's tau for this. So we had an effective intervention. We were really excited about this study. Secondarily, the people in the intervention arm, we had a 26% absolute reduction in the use of LVADs. So people who were a little more informed and making more value concordant decisions were less likely to get an LVAD. I'll show you in the implementation work, the sites that didn't adopt our decision aid, a lot of them said they're worried about this. They don't want their volumes to go down. But that wasn't our goal. That was not our goal. Our goal was to inform patients, not to reduce LVADs. It's important to say. So after this, we decided to go big. This was a really fun study. So Picori, who funded that last trial, said, all right, if you have we want to make sure we're renewed, basically. This was before Picori got renewed by Congress. So to do that, if you have an effective study, we're going to give you money to implement your effective results so we can show more impact. So like, okay, we got an effective result. Let's do this and let's implement this nationally. Which felt like a very lofty goal. But there's 175 programs. They're a pretty tight-knit community, this heart failure world, because they're on the phone with each other, sharing hearts. A lot of people kind of know each other. So even though it's a national implementation, it's still implementing within a community where the communication channels are still not overwhelming to navigate. And so we started this dissemination adoption, trying to get sites to adopt this program. And this is our adoption graph over the 4 years of this study that we've just kind of completed. We're actually trying to package this up for a health affairs paper to see if they'll bite on that, because this has been an incredibly successful implementation experience. The green are the sites that have adopted. The little black bar at the top are sites that refused the decision aid. And then the yellow were people that we hadn't contacted yet, and the red were people that are people that we contacted but didn't adopt yet. And then the red were people that we contacted. And this is just how we kept track of things over time. We had a few people who'd signed on at the beginning to start right away. PCORI needed us to do that to give us money to show that there were at least a few people that would do it. We had a few that we'd contacted but hadn't yet started, but that were also willing. And then we did a bunch of national surveys to basically build a network of people. And we ended up getting a contact at every 175 programs. So we have this network of LVAD, advanced heart failure programs that we can work with. An adoption was a really low bar. Adoption is not implementation. Adoption is, hey, we got a contact. Hey, will you let us send you some decision aids and some materials? Sure, great. So then we send them a box of 50. We basically chummed the waters and gave them a bunch of tools. This box this big, we kind of played with the design, put fun stickers on it with our logo. So like a little present showed up and had people look at it. So it didn't just hide as like an email or a link in your email. It was something that you got. And that was the adoption. And then we surveyed these programs every 4 to 6 months with a little 6 or 7 item survey. Did you use the decision aid? What proportion of patients did you use it with? How many patients did you do in this time period? And we kind of gathered some crude statistics on how it was being used. And now at the end of this, at the end of the trial, of those 175 sites, 123 are using this decision aid. And 80 of those sites saying they're using it always or a standard of care. So half the sites in the country are using this tool. The other 23 are using it frequently. A few are using it a few times. And then we had 6 sites here that refused the decision aid. We've interviewed a subset of 30 sites, some that adopted and some that didn't, to find out why did you do it or why didn't you do it. And the ones that didn't do it, a lot of it was logistical. We were busy, the pandemic happened. And then we heard a few quotes of like, well, we're in a competitive city. We have to do 10 a year. We don't want our volume to go down. We don't have that problem here. We're like the only tertiary center within 300 miles. But you go to a city like Boston, there's like 5 LVAD programs in a 50 square mile radius. And they have concerns about meeting their 10 a year just to maintain accreditation. So have a little bit of empathy for wanting to keep your volume up, but not a lot. But we had some fun interviews. Like the highest volume surgeon in the country said, I want to do as many LVADs as I can, but I never want to do them in somebody who doesn't know what they're getting into, because I've seen them go really badly. I think that's what's really different about the LVAD space. I don't think it's our tool. I think we just picked the right decision to work with. I think there's just general consensus, even among the docs, that, okay, I've seen people do poorly. I'm a surgeon and I've seen people do poorly. I want people to be prepared. Usually we get a lot, like it's easy in primary care. People see the pros and cons. Everybody wants to implement things. They just don't have time. You go to these specialty settings where they may have a little more time. Like in this case, there's also an LVAD coordinator who's in charge of like 20 patients. That's their whole job. And they do a lot of education. And so it was really easy to implement. We didn't have to find somebody who didn't have time. You had somebody who already had time to implement. And they didn't, and we interviewed those people. They didn't like the industry tools they were giving out. They felt they were biased. They're like, but this is the best we've got. So they were very happy to have something that felt less biased to plug and play. So I don't think it's us in our decision. I don't think, I mean, I like to think it's our design and we did a great job, but I think we just picked a decision that was right for this, which is why I kind of started off saying, I think there's some decisions that are better for shared decision-making than others. I do think deep brain stimulator is another good one. Big trade-offs, people see pros and cons of it, doesn't always work. When it does, it works really well. I think that's gonna be another good one. I get a lot more pushback on the defibrillators, I'll tell you what, because it doesn't feel as fateful. They're a little outpatient, they're a little healthier, it's a little more primary prevention, and there's a Medicare mandate, they have to do it. And in our implementation trial, not only were the control group contaminated, but then the last 3 sites we implemented at 6 sites over time. The last 3 sites were during the pandemic, and they basically didn't implement because they're all getting sucked in to cover ICU shifts while ICU docs are getting sucked in to cover COVID shifts. So the trial, all the outcomes kind of move in the right direction. A few of them are positive, but none of the primary outcomes. So it's a negative trial with some major problems. So I'm not even going to show that data. I'll present it, but it's really frustrating to me. But it's interesting to contrast these two things. We talked a little bit about the LVAD versus the ICD. Who's going to deliver it? How will it be delivered? These were very different. I think I went through this just looking at the time. I think I'll jump through to the last slide because I think some people asked me to present some things. Medicare is starting to mandate things a little more. They've done it for lung cancer screening was the first one, and then they've done this left atrial appendage and defibrillators. There's just a proposal for carotid stenosis. And we've had actually a few calls with Medicare about LVADs as maybe the best place for them to mandate shared decision-making because we do have evidence to support it. But this is just ending with like 1 minute. We got this AI grant and it kind of builds on that LVAD experience. We said, okay, the defibrillator, I spent 3 years doing interviews and surveys, and then I made a tool and I showed it to the cardiology group. One of the cardiologists said, I would never show this to my patients. There were all kinds of design problems. And then I've spent 5 years with a Beeson studying it, doing a little pilot, and then this R01 that was failed. And then the LVAD we did much more quickly. And I actually think we can do a lot of these things a lot more quickly. So I teamed up with Russ Glasgow and we said, let's make us one of these center grants that the chancellor said, I want things in front of patients. Let's put things in front of patients. Let's say we'll develop 10 patient-centered tools. They're not all decision aids, but something patient-centered. And we'll do them in 2 years each. We'll do 4 to start out, and then we'll have these little pilots to do 6 more that people will be able to apply for. And anybody who gets one of these pilots will have to go through our steps using a lot of the implementation science stuff. You have to go through this rapid discovery phase of stakeholder engagement, partner engagement, a rapid design phase, and then a rapid implementing and pilot testing phase, and then get to dissemination. So you get your key messages. And this was the figure in our central figure in our AI grant that kind of summarized a lot of the work. But this is what we want to do is how do we develop things for patients and how do we measure the business mindset of rapid development and get things to market with the academic mindset of rigorous science? And can we push both and then write a bunch of papers and develop some meta tools that people can use to rapidly take an idea and not spend 17 years going from idea conception to implementation, but let's do it in 2 years. And can we do it? And that's what we propose in the AI. And it's going to be hard. It's going to be really hard. And we're going to have a lot of lessons learned along the way, but it's going to be a lot of fun. I'm actually really excited about it because it's kind of, you get these grants and sometimes it's like, wow, I have this grant, now I have this work, but it's like, wow, this is a grant doing work that I want to keep doing. So that's kind of fun. But anyway, that's my talk. 5 minutes left for questions. And we'll go from there. I'm also happy to try and remember to repeat the question as someone who's frequently online during grand rounds.
Thank you for a great talk. And actually that clock remains fast, so things are good.
Oh, good. I forgot about that.
Thank you so much
good.
for a great talk. I was hoping you could talk a little bit about how you view decision aids and if they've adjusted at all post-COVID, this like patient revolution that you talked about. I think I feel really present in post-COVID care in terms of the mistrust and distrust in the medical system post-COVID, and if you've adjusted any of your strategies or how you approach that, or if you've seen any literature about that.
Oh yeah, no, I was actually working on an editorial last night. The last paragraph is, I think shared decision-making is one of these strategies to communicate uncertainty, communicate honestly, and maybe rebuild some trust. As I've sort of Monday morning quarterbacked the pandemic, there's a lot of criticism of us in our public health messaging. We had a lot of hubris and we did not communicate uncertainty at all. And even if we did, people didn't believe it, but I actually don't think we communicated uncertainty very well. And then when uncertainty emerged, people just didn't trust the whole thing. And I had 3 patients in clinic last week who aren't getting any vaccines because of this. And something about me, I think it's the way I look. I invite these curmudgeons that don't want to get vaccinated. I have like a lot of them because I think they think I treat them nicely because I try to treat them respectfully. But I don't know. I haven't seen a lot about it, but I do think getting better at this is one strategy to navigate the rebuilding of trust that I think is on our shoulders. I think it's square on our shoulders. Dr. Lamb.
Hey, great talk.
I think it's on.
It's on. Hey, great talk. I was curious to know, how do you deal with this decision as it relates to costs? That you've brought up, I think, in one of the earlier slides, that physicians are worried about cost to patients. So what happens if they go through this shared decision? They're like, I would love an LVAD, and then it's like, but it's not covered. Like, how does that get folded in, or how does that even get folded into the concept of it?
So I think a decision aid should meet the decision needs. And I think some decisions have a need of talk about costs and some don't. Like if you're doing about should I get a PSA test, you probably don't need to spend a lot of time talking about costs. Now, if you were going to make a decision aid about long-term care entry, for example, I don't know if you thought about that. You're going to have to talk about cost. So we have one decision aid we made for the ARNI medicine, the sacubitril valsartan, the Entresto for heart failure. It is a little bit more beneficial than an ACE inhibitor, like a 3% greater benefit, a little bit more hypotension, but it's a lot more expensive. And so that's the first decision aid where we actually really dove into costs. And we have a whole page in that decision aid talking about costs of medicines. And we really struggled in the design of that. We had a lot of patients help us, but we have like, you might be patient A where you have great insurance and here's your average copay. You might be patient B where you have marginal. You might be patient C. Here's some instructions on how to get your cost. Call your insurance company or call this. And so we tried to help them navigate the costs because that's the other challenge. Larry Allen, his new PCORI grant he just got is about heart failure medicines, and he has an intervention we made that actually has costs over on the right. It's just dollar signs, like $1 sign versus $3 signs, but it at least brings costs into the discussion. And we were just in a site for a trial that somebody from Emory wrote, where he was studying cost and decision making, and randomized people to get cost information or not. And the people that got cost information, they had recorded encounters, and there were more discussions about cost when you got a tool that had some cost information, and that was their primary outcome. And that actually was an AHA late breaker abstract this year. I think it's something we got to work on. I mean, the other challenge, I don't think there's a barrier. I think we'll talk about it, actually. I think the reasons we don't talk about it are not because we don't want to talk about it, it's because we don't know what their costs are. We don't know what their insurances are going to cover. So the uncertainty around what their individual costs are, I think creates it hard for us to talk about it. I don't have a problem talking to patients about costs. I doubt many of you do either, except that we don't know what the costs are. That's my hypothesis anyway.
Hey,
Dr.
Dan,
Monroe.
great talk. I finally have a better understanding of what you do now. So,
That's how I felt with you last week or a few weeks ago.
I gave a talk last night just talking about menopausal hormone therapy and how the clinical trials from a little over 20 years ago has done so much harm to women's health because of the lack of understanding and putting into context those risks, kind of like how you were explaining it. We talk about the relative risks, which sounds scary, but then when you put it in context, and I know I have a lot of friends who say this, and even clinicians who say, well, you're going to get breast cancer if you take this, or you're going to have a heart attack. When you put it in context, and it's like, well, if I was to treat 10,000 women, age 50 to 59, you'd see 5 maybe extra cases of
Yeah.
breast cancer. But you have all these other benefits that would come along with it, but they don't
Exactly.
see that. And my question is, how do you train doctors? Because there are some doctors who will not prescribe hormone therapy to women because they have that bias or they don't understand the risks. And you have this unnecessary suffering. I tell my friends, there's no badge of honor to go through menopause without taking hormones if you're miserable,
Yeah.
right?
You're right.
And how do you just get that message across? And do we have to just train kids going through medical school right now, how
Yeah.
to interpret the data
Yeah.
and inform their patients properly and leaving their biases at the door?
Yeah. I mean, I don't know the answer to your question, but I share the question. I do think it's some training. Tanner Caverly, who used to be here, he's now in Michigan. He's had this belief or this theory that we need to get in the FDA approvals, natural frequencies of the benefits and the risks instead of these relative risks. Like, what is the absolute benefit out of 100 or out of 1,000 people? What is the absolute risk for the side effects? So you could actually have those discussions. Because I also think docs want to give the right data to patients. We just don't always know it, don't always have it. I think that's one of the things where tools can be helpful, especially in some of the more where you do have, like that's one where I think the data really matters. And there are a couple hormone replacement decision aids. I haven't looked at them in a while. But yeah, and I can look up on the Ottawa site. There's a whole library of decision aids, and I know there's a couple because it is an interesting area where preferences really matter. I have one patient on HRT who's an opera singer, and anytime she stops it, she gets hoarse. So the ENT people said, you need to take estrogen. And she's like, I know there's a little risk, but I'm going to take this because I like to sing. I'm with you. Let's do that.
Thanks for a great talk. I'll just share an anecdote that really appreciated last week in clinic. One of our residents pulled up a lung cancer screening decision aid on the computer, showed a pictograph, and that was integrated into clinical care. So thanks for a great discussion. And we have 3 books to give away. So if you have not received a book and would like a book, because I know many people have, and I think Peggy has them. So anyone who's interested in them, yes, go.